All right, everybody, welcome to our final video in the neuromuscular and chest wall disease series. This video going to be focusing exclusively on chest wall diseases. So that might sound a little bit funny to you right now, but I'm gonna clear that up real quick. It's really not that hard. Basically, what we're talking about is any disease process that causes a deformity in the chest wall or decreases the compliance of the chest wall. Which results in a restrictive defect, which, as we know, prevents regular expansion of the lungs. So any kind of deformity, alteration, change in shape, structure, anything like that, anything that makes this chest wall an abnormal shape for one reason or another, if that's preventing the lungs from expanding, which we're going to talk about here in a sec, remember, that's preventing the lungs from expanding to their normal volume, so that's a restrictive disease process. This could also be caused by the loss of rigidity of the chest wall as well. It's going to be a massive chest wall injury that we'll talk about too. So let's talk about it. So if the lungs can't expand, patient's likely to develop atelectasis. We know that. Secretion clearance issues with secondary plugging and infection. We know that, regardless of the health of the actual lung tissue. We already know that. So it's just saying that the patient can still have severe pulmonary complications even though the lungs themselves are healthy with the diseases that we're talking about here coming up. So first one, the list. We've got 6 of them. And realistically, we're going to roll the first 3, scoliosis, kyphosis, and kyphoscoliosis. We're going to kind of roll those all into one because we're just swapping terms around there. So it's pretty easy. If you understand one of them, you understand them all. We'll talk briefly about ankylosing spondylitis. We'll talk about pectus excavatum, pectus carinatum, and then this massive chest injury that we call the flail chest. So let's see how quick we can do this. Scoliosis and kyphosis. So scoliosis, I'm sure you guys have heard of this. You probably got checked for it in junior high and all that stuff. Basically, this is lateral curvature of the spine. So we have our guy. So here's our patient. We have patient right, patient left. And then if we look at him from the side, so here he is. He's got his arms up to the side. So let's say now he's looking this way. Kind of looks like a mischievous guy, but whatever. So this is us looking at him straight on. Patient right, patient left. This is the front and this is the back of him. So this is his anterior. This is his posterior. Spines have a normal curvature. They should be curved a little bit. They shouldn't be totally straight, but what if it gets to be extreme? So let's talk about it. Scoliosis, we already said this is lateral curvature of our spine, and it makes an S. So lateral, meaning side-to-side curvature of the spine. So instead of this patient's spine being right in the middle right here where it should be, what are we going to see? We're going to see a spine that is deviated off to one side. There's our lateral curvature. Or maybe it goes off to this side. Or maybe it does like a little S shape. Something like that. It's lateral curvature, it's side-to-side curvature of the spine that shouldn't be there. So that's like this patient right here that we see in the bottom picture. The spine is just kind of doing the meandering back and forth, and then you can see after some extensive surgeries and lots of hardware, they've managed to straighten that spine out pretty well. But that's scoliosis in a nutshell. Kyphosis. So we're looking at forward curvature of the spine. So instead of this patient's spine kind of, holding them nice and upright, what we're going to see is that spine going like this. Them curving forward, essentially them leaning towards the anterior. So even though the patient would be leaning towards the anterior, this curve, the curve that makes them lean towards the anterior, is a posterior curve, and that gets kind of confusing to understand at first. This spine right here curves towards the posterior. That means this patient's head moves here towards the anterior. So forward curvature of the spine. That might be a little confusing. I'll just restate it one more time. So they're like this patient right here, their head inevitably ends up forward. That's the kyphosis, but it's because there is intense posterior curvature of their spine. Their spine is curving towards the posterior and it's forcing their head forward. Now you can have any one of these by themselves. We can have scoliosis by itself, we can have kyphosis by itself, and then we can put them together and we call it kyphoscoliosis. So there, I told you we've got those first three diseases and we covered them all in one. So you know scoliosis, you know kyphosis, you put them together and you get kyphoscoliosis. So it's combined lateral and forward curvature that results in a severe restrictive defect, not just a restrictive defect that you would get from either one of these alone. It's a severe restrictive defect that significantly limits lung expansion. What's actually happening? Why does it limit lung expansion? You just have to picture that there's an expected amount of room for the lungs to expand, having the spine and everything midline and having normal posture. And if you start leaning forward significantly or you start curving side to side significantly, you just can't take as deep of a breath because it crushes all the volume out of your lungs. So a good way to try to do that is to, right now you can just, kind of put your hands right at the bottom of your ribs and then just lean forward as much as you can and try to take a big deep breath, or lean way over to your right or your left side and try to take a big deep breath. You will noticeably draw in a smaller breath because there just isn't room for your lungs to expand. Ankylosing spondylitis, kind of a fun word to say. Not fun for the patients who have it, but what's actually going on is it's a disease of the connective tissues. That's what a rheumatologic disease. So like a rheumatologist or rheumatology, that's an entire study of medicine that's dedicated to studying and knowing the diseases of all your connective tissues. So that's rheumatology. So ankylosing spondylitis is a rheumatologic disease that causes chronic joint inflammation and leads to fusion of the vertebral bodies and costovertebral joints. So what does that actually mean? Well, let's take a look at our spine. So here you've got your spine, which I'm not going to draw in purple. Here's our spine, and we know it's got a bunch of different levels. So I'm just trying to draw all our different vertebrae here. So no need to be too detailed. All right, you guys get the idea? Spinal column and vertebrae. And up top in the thoracic region, we have these big curvy things that go around like this. I'm going to draw this as though we're looking at the patient's posterior, so we're staring at the patient's back. So you've got ribs that loop around to the front like this, and I'm not drawing them very well, and that's okay. So your ribs all curve around towards the front. You know you would have a sternum up here somewhere, but I'm not that good at drawing three-dimensionally. Anyway, all we need to get is that this is our vertebrae, these are our ribs. And where those vertebrae and the ribs come together, that's called the costovertebral joint. So vertebrae, costos, the ribs, where they come together, this area right here, that's the costovertebral joint. It's where the rib and the vertebrae come together. So you've got them on all sides. I'm just trying to point that out. This is the area we're talking about, and they've got a great picture of it in your textbook as well for anybody who's following along with their textbook. So normally this should be, this should be a relatively, I don't want to say squishy, that's not the right term, but it should be a pliable joint. It should be able to move a little bit. Like as you take a big deep breath, and expand your chest, your ribs move a little bit, and if your ribs were like absolutely fused to your spine, they wouldn't have that mobility and you wouldn't be able to expand your chest as much. So that's basically what's happening here. Instead of these being a little bit mobile and moving around when you breathe, these are just absolutely fused, solid joints now. It's like really hard, bony tissue. And now those ribs aren't free to move anymore, which means your chest wall doesn't move as freely, and that's where your restrictive impairment comes from. So it's not a decrease in lung compliance, it's a huge decrease in chest wall compliance. A lot of times we see this along with severe kyphosis, which we already learned about. Then this is another one of those diseases that we can treat with immunosuppressants because it's thought that there's some sort of autoimmune component that causes this to happen, along with other specialized drugs. corticosteroids, all kinds of things, just again aimed at stopping that immune response, stopping the inflammatory process, because it's this constant inflammatory process in here that is making this happen. And eventually the body says, you know what, I can't deal with all this inflammation, I can't deal with this constant damage, and instead of layering scar tissue in this case, it just makes a big, hard, bony structure that decreases chest wall compliance. So that's your ankylosing spondylitis. Pectus excavatum. So this is just an anatomic variant that you might see from time to time. It can be very minor, or it can be like really, really significant, anywhere in between. The way I always remembered this is it looks like the chest has been excavated. So pectus excavatum, it looks like someone took a bulldozer or a tractor and scooped out their chest. So it's been excavated. So in medical terminology, inward displacement of the sternum. Instead of it being like just a flat bony plate, it actually is formed so that it pokes inwards. So as you can probably imagine, in severe cases, it's going to result in a restrictive lung defect, because it's not only taking up space where the lungs potentially should be from this massive inward curvature of the chest wall, but this isn't a normal mobile chest wall. It's not normal chest wall that is that's pliable and moves a lot. This is not its usual makeup, so it's not as pliable. It doesn't move outwards. It doesn't stretch out as much. So your lungs don't stretch. Your lungs don't stretch out as much. So just remember, excavatum. It looks like the chest has been excavated and it's been scooped out a little bit. So got some pictures there for you. Also, something that we see pretty commonly in patients who have Marfan syndrome. Now, the other side of that coin. There's pectus excavatum and there's pectus carinatum. So carina, we already talked about that. That's carina, like keel of a boat, so it comes to a point. We have a carina in our airways that comes to a point, and if the patient has pectus carinatum, it means essentially that their sternum comes to a point. So sometimes people will refer to that as a pigeon chest. Properly, it's known as pectus carinatum. So if we look at our little pictures here, we can see that this is not a normal makeup of the chest wall. It doesn't have the compliance or the ability to stretch. It doesn't have the ability to stretch as much as a normal chest wall would. So translate that to what it means for your lungs. If the chest wall can't move, the lungs can't move as much as they should be able to move. So there's our restrictive defect as a result of a loss of chest wall compliance, not a loss of lung compliance. And then our flail chest, this is going to be our last one for the day. A flail chest is something that you see with a massive chest injury. And let's just go over our definition here, at least our definition that we're going to use for testing purposes and on the NBRC and everything. So a flail chest for us, our definition, which is the one that we need to be aware of. Some people might change this up a little bit, like if you, I don't know, if you read like a trauma book or something, they might describe it slightly differently. This is our description. This is the one we're tested on. This is how we recognize flail chests. So a chest injury that involves a free-floating segment of chest wall as a result of multiple broken ribs. So it's not just a bunch of broken ribs. It's a specific way of breaking these ribs. So commonly defined as 3 or more consecutive ribs broken in 2 separate places. So I'm going to draw that out here in a second. Let's go over what happens. It's going to cause a paradoxical motion of the chest wall. And anybody who's thinking back to medical terminology, what's paradoxical? Anything that's a paradox is just something that you're seeing something happening that you don't expect to happen. So basically what that means is we expect the chest wall to move out on inspiration and back in on exhalation. We're seeing the opposite of that with this injury. So we'll draw a picture here in a sec. Don't worry. The big problem with this is not only it's going to be really, really painful, you got broken ribs that can puncture lungs and cause pneumos and things like that, but it's going to impair that all-important pressure gradient that ensures that when you inhale and exhale, lung air actually moves in and out of your lungs. Sorry, I kind of mixed that up. And eventually, if this is bad enough, it'll lead to respiratory failure because they're not really pushing air in and out of their airway when they breathe. They're kind of pushing air back and forth between their lungs, or what we call a Pendeluft effect, kind of like a pendulum or air swinging back and forth. And that can lead to respiratory failure, not to mention that it's incredibly painful. And lots and lots of chest wall pain is going to impair respirations anyway. So we are typically going to see this along with other chest injuries that we'll learn about, like pulmonary contusions, hemothorax, and pneumothorax. We typically tend to see all these rolled into one. So let's draw out our ribs. Here's our sternum, and here's our ribs, and they go around like this. Now, notice they were really specific. It had to be 3 or more ribs broken in 2 separate places. So I'll just give you guys a couple of examples. If we break our ribs, I'll make the breaks big. So if we break our ribs here, and let's say right here. Well, there we go. That's 3 broken ribs. But that's not consecutive ribs, and they're not broken in 2 separate places. That's just 3 rib fractures. So even if I made it, let's repair them. Let's put them all back together. What if it was, all right, here we go. There's a break, and there's a break. We're still not going to have a flail chest because it's got to be 3 or more of them all in a row. They got to be consecutive, and they've got to be broken in 2 different places. So let me show you what I mean. 3 of them in a row. So let's break this one, and that one. So these 3 ribs right here are fractured. They're broken. So that's our 3 consecutive ribs, but they've got to be broken in 2 different places. So let's say they're broken right here. That's break 1. Right here is break 2. And notice it's the same ribs. So this right here, these breaks, 3 consecutive ribs, 2 or more places, that's what's going to cause this flail chest. That's what's going to cause this loose, free-floating section of chest wall that's going to move paradoxically when the patient breathes. So we rely on our ribs quite a bit to give our chest wall the rigidity that it has. So if we start breaking a bunch of these ribs and we break them in a particular way, we're going to lose the rigidity of the chest wall. So what we did, basically this right here, this whole area isn't connected to anything. All we have is soft tissue holding this in place because the big bony structures that were holding it are compromised, they're fractured, they're broken. So the only stuff we have that's holding this together is soft connective tissue, which means it's going to move inwards and outwards. So what does that actually mean for our patient? Let's go on to my next slide. This is basically what they were trying to draw here. You've got a big broken loose section of chest wall. Well, how do we get this paradoxical movement? As we take a big deep breath in and we expect our chest to expand outwards, that's actually creating negative pressure in the chest. If you have negative pressure in the chest, that's a vacuum, which is essentially just going to suck this loose portion of the chest wall inwards. So the whole rest of this chest will move outwards as the patient breathes in. This flail segment, this broken piece right here, is actually going to get sucked inwards, and that's what it's showing right here. The patient's inhaling, so they start to inflate this lung, and they suck this portion of their chest wall inwards because there's nothing to hold it in place, so everything just kind of moves back and forth. Same thing with exhalation. As the patient goes to exhale, sure, their chest should return to normal size, their AP diameter should decrease, but the increase in pressure in the airways as the patient exhales pushes this loose section outwards, which is the opposite of what we expect. We expect the chest to move out during inhalation, back in during exhalation, but the exact opposite happens with your flail chest. That's the paradoxical movement, and that can only happen if you have a loose, free-floating segment. So what should we do about treating this? Obviously, a lot of it is going to involve pain control. The patient's probably going to need positive pressure ventilation, at least for a little bit, just to make sure that they can ventilate while their chest wall is being stabilized. The stabilization is actually done surgically, whether they have to go in and put little pins or whatever in to like piece the ribs back together, or however they end up doing it. The impaired painful ventilations as a result of the loss of chest wall rigidity also are going to cause ineffective secretion clearance because you're not effectively moving air up and down the airways. Like we said, it's kind of swinging back and forth in between the lungs, and that's just going to contribute to all the problems we're seeing going to contribute to the difficulty breathing, respiratory failure, and everything else. So we just need to stabilize and repair that chest wall, and as soon as this patient isn't in a horrible amount of pain and their chest wall is healed, they'll be able to breathe again. But that's the idea of a flail chest, commonly seen in trauma patients of any type. So that's the end of our neuromuscular and chest wall disease series. So questions to ask yourself, I like to just throw these in there at the end. So as you're studying, make sure that you understand why neuromuscular and chest wall diseases fall under the category of restrictive diseases, even if the lung itself is totally healthy. What are some common respiratory and non-respiratory complications of neuromuscular disease? We've talked about a bunch of them, and no matter where the problem lies, this is important to remember, no matter where the problem is, brain to muscle, when do we get involved in the care of the patient? So in case you can't think all the way back to when we went over those, basically we get involved in the care of these patients if their ability to maintain effective respirations is impaired, so they can't draw enough air in and blow enough air out, or some of those wonderful airway protective reflexes that we naturally have become impaired.